Good afternoon, everybody. Welcome to Pediatric Grand Rounds. I'm Meg McNamara. I'm the Residency Program Director, and it is my distinct pleasure to be here this afternoon to introduce Grand Rounds. I'm going to start with a land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I am going to introduce Dr. Mindy Ju, who's one of our stellar clinician educators here from the Division of Critical Care, and she's going to introduce our guest speaker today. Thank you.
Good afternoon, everyone, and thank you, Meg, for that introduction. I'm Mindy Ju. I'm a pediatric critical care medicine physician, and I also am the Abraham Rudolph Chair in Education for the Department of Pediatrics through the Academy of Medical Educators. And with that wonderful privilege, I have the opportunity to bring our speaker today, Salim Razak, to come speak to us. So briefly, Salim Razak is a pediatric intensivist at BC Children's Hospital and research at the Center for Health Education Scholarship, or CHESS, and BCCH Research Institute in Vancouver, Canada. His areas of research are around anti-racist pedagogies and health professions education, which we will be talking about today. And he was a little background. He was born in Trinidad and Tobago, but of South Asian descent. And we've had a lot of conversations about that over the last few days of moving all over and having different identities. Moved to Canada when he was school aged and has stayed there the rest of his career. He completed his MD at the University of Toronto, followed by a residency and fellowship at the Montreal Children's Hospital, McGill University, where he was faculty from 1996 to 2022, had several positions in educational program leadership. Every time I have a conversation with him, I find out a new thing he did. He was program director, residency program director, associate dean of admissions, and many others. And is currently senior faculty advisor to the Respectful Environments, Equity, Diversity, Inclusion Office at UBC. And I just want to say we're so grateful to have you here, and many of you have already met him in different settings, and hopefully we can continue learning from him today. And I just had said this to other groups. I think this is the beginning of a conversation, and hopefully continue to open some dialogue about where we are in pediatric medical education. So welcome.
Thank you, everyone. It's a real pleasure to be here, and I'm a little bit starstruck because you said that you are the Abraham Rudolph Chair, and it just twigged to me that that's Rudolph's textbook of pediatrics. That's amazing. It's so much history to kind of think about. Here's the title of what I'm going to talk about, and I don't even know what it means, okay? But I looked at it and I said, oh my goodness, what did I do, right? But I hope to bring it together for you and get us thinking about how we are as pediatricians, as child health specialists, child health subspecialists in this highly unjust world that we live in, and what it means for us to, in our particular areas of practice, what that means for us and what that means for us with respect to training and education of the next generation. I'm gonna, there was a land acknowledgement, and I'm grateful for that. I want to acknowledge that I actually, I live in a place, Vancouver, Canada. It's the home of the Coast Salish people. and my university is built on something called the University Endowment Lands. And I reflect on, who endowed what to whom under whose authority, and who took it away from whom under whose authority. When I think of California, I have a little thing that I do every time I come to one of the sand cities of California. I always go to the mission, whatever the relevant mission is of the place. I didn't get to go to Mission Dolores this time around, but I did last time around. And, I kind of reflect on the Ohlone people and I reflect on the mission system that really, for me as an outsider, it created the relationships between peoples that define California today. For me, when I observe California as an outsider, I see the conversation a little bit hidden. It's hidden by other things like language, what language you speak. Do you speak Spanish? Do you speak English? And so on. But I believe that series of relationships started in the mission system has really had a huge impact on what California is today. And I did look up the Ohlone Nation because I wanted to learn about the place. And I would highly recommend you visiting the website of the Muwekma Ohlone people, which if you look there, they have traced their ancestries back to the baptismal records of Mission Dolores, actually. And you'll see a lot in there that resonates about what California is. I have, I thought I should tell you that I have a few things. I have a role as the Royal College of Physicians and Surgeons of Canada. I'm a CanMeds educator. CanMeds are the core competencies, a little bit like the ACGME competencies. So the Royal College is a little bit like the various boards that regulate subspecialty education, except it's one college that does all of the specialty education. So they give me a little bit of a stipend to be there, but I got to tell you, it ain't that much, and my academic freedom is worth a lot more than that. So I hope I want to tell you that I'm speaking freely today. I'm gonna start. I want to say that I would feel like a fraud to speak about equity-based topics, which is what we're going to talk about today, without recognizing the world we're living in right now and the conflict in the Middle East that has really everybody who's participating in the conversation around that has trauma that they bring to that conversation. And I do as well. And I just want to recognize with anybody, wherever you are in this conversation, that I'm going to try and hold space for you as we do this. And I hope that you will hold space for me as well, because I too am traumatized. I want you to think about what got you into pediatrics, right? What got you into medicine? What got you into pediatrics? And I sort of think I could tell you that I liked critical care, I liked the diseases, I liked the physiology, but it really goes back to these two things for me. And if you give me a second, I'll explain. So I don't know if you did this here, but when we trick-or-treated in Canada, we had these little UNICEF boxes, and we would sort of go to the house and we would say trick or treat UNICEF, and they would throw in some pennies in there, and then you brought it to school, and then that went to UNICEF. And I reflect on those moments doing that, and there's nothing controversial in the term UNICEF, United Nations Children's Fund. What is controversial about that? But I think I think that participating in something bigger than myself, like just a little thing like that, really showed me that the things that we do in pediatrics, like, we give someone antibiotics because they have meningitis, um, that's going to affect the next 8 or 9 decades of their lives. Our action is going to affect the next 8 or 9 decades of their lives. And that's what's so beautiful and lovely and amazing about pediatrics. I put Guess Who's Coming to Dinner there. I don't know, you folks are probably way too young. I want to make sure that you know that I saw this in reruns, okay? Like not the real show. It actually was set in San Francisco. San Francisco has one of the starring roles in it was, I remember seeing it and saying, what a beautiful place that is, because it obviously was set in one of those mansions that are on top of one of those hills that we have in this city. But it was about an interracial couple that go to the wife's parents to introduce the new couple. They got married while on vacation or something like that. But what was amazing about this movie was that Sidney Poitier was a doctor at the World Health Organization. Like the whole premise of the show was that he had time for dinner and then he had to take a flight to Geneva. And I guess what was important to me there was a sense that we're part of this larger whole, and that we are, and very important for me as someone, like a racialized person, was to see Sidney Poitier be a doctor as well. And that was, those are the things that I relate that brought me into medicine, into child health. What's going on now, right? So we live in a world of increasing subspecialization, right? It wouldn't be unusual for there to be a division meeting of our cardiology colleagues where they're talking about the next recruit, right, that they want to bring in. And they say, you know what? I think we should have a diastologist, with someone who's studying, I want to say it in French, diastologie, diastology, right? I want to meet that person because I feel that person would probably be very relaxed. But, we don't even talk about a pediatric cardiologist recruitment. We're in this, and I singled out cardiology, but, in critical care, we talk about, I need to bring in someone who's a neurocritical care physician. We need to, these kinds of things. So that world that we are creating, it's coming because knowledge is becoming more and more specialized. And, it can't be held in one person, but that isn't the only reason, right? Like, I think we have to become clean about that. There's a lot of economics at play there as well. People, wanting to stay in a place and becoming more and more specialized. And in that kind of world, it's very, very hard to connect back to that UNICEF. It can be very hard to connect back to UNICEF and the real reasons that we were here and why are we part of a whole. So I hope to have a bit of a conversation about that. So let's think in terms of medical education, okay? And, many of you in pediatrics are going to be involved in medical education. And I want, think about teaching medical students, right? So many of us are involved in these doctoring courses where we teach medical students clinical skills, and they see a patient and you kind of help them through. So traditionally, what we teach is that, there's a kind of like a triad, right? Like there's a doctor, a patient, and an illness, right? So we teach medical students to take a history. Okay. And then they kind of do something which we label as clinical reasoning, and they come up with a mental model of what's going on, and they apply that paradigm to the illness, right? And the illness is constructed as something that affects health. And, much of what, I don't have time to go into much of the literature of this, but there's a significant literature that really talks about what's been lost in this kind of way of looking at things, that really what doctors are doing so much more is interacting with the illness rather than the patient. and that there's something that's kind of getting lost there in that interaction, and it's being made worse by very stressed out healthcare systems, by taking a history from a computer on wheels instead of looking at the patient, right? And I want to think about that as well. It can be really troubling for us to understand a patient's context when that's happening. So I thought I would start with a couple cases from my own practice to illustrate the ideas that I want you to think about. And I want to let you know that everything I'm talking about has a literature basis, some of which is my own, but also many others. And I will try and remember to give you some of those references as we go through, right? So the first case is Jamal. So Jamal is a Black boy. He's an 11-year-old boy, and he jumped into the deep end of the pool by mistake instead of the shallow end of the pool, and he arrested at the scene, was resuscitated, and he was brought to the emergency department and ended up in the ICU where I work. Actually, the old ICU where I worked. He spent a couple of days developing severe hypoxic ischemic injury that became apparent. And he ended up, discussion with the parents, he ended up being disconnected from life support, and then he passed away, right? So then we discuss mortalities, and I know that in our PICU here that we discuss mortalities as well, so very similar setting. So every death that occurs, mortality is discussed, right? So two of the older attendings, that wasn't me at the time, I was younger, two of the older attendings, they're like those two Muppets in the Muppet Show, right? Like, so they're the kind of like the Siskel and Ebert of mortality and morbidity rounds. They sort of occasionally inject wise and sage comments, but they often talk amongst themselves, right? And they sort of talk to each other, and they say, I remember that there's been like 4 Black kids who have, either had severe submersion injuries in this summer, and what's that all about, right? And that's what they say to each other, but it now doesn't really go anywhere, that conversation, right? Like that the rest of the conversation around the morbidity and mortality is that basically there was nothing in the care that we needed to think about as requiring us to review it, right? So what I want to pose it to you is that such a thing that occurs, so in ICU, such a thing that occurs is a missed opportunity for us to teach important parts of our job. And what's missing there? What those two engaged in, though they probably would not have labeled it as such, was that they engaged in something called structural competence, the development of structural competence. So what is structural competence, right? So structural competence is the ability to appreciate the pattern from the noise, right? And when I think, I came of age as a medical student in the late 80s. So 86 to 1990 was my medical school. And I really am saddened that you're not shocked at the timing that I have told you. But there you have it. That was the time of AIDS, right? Like that was, I always think of I feel like my generation of physicians are defined by that, right? We may yet be defined by COVID. But I really am marked by it because I remember single patients on a single ward because they were afraid to have them be with other patients and all kinds of things. But I think about doctors in this city. Some names that come to mind. They're in the pantheon of HIV doctors like Marcus Conant and others, and doctors in New York who had practices with a lot of gay men and noticed Kaposi's sarcoma, right? And then, they alerted the authorities, and they had the also the desire to act and help, on behalf of this population. So that's what I think we need. One of the things we need to teach, right? We need to somehow teach the appreciation of patterns of illness that are beyond the walls of the hospital that we're in, or beyond the walls of our clinic. And that is structural competence. And what is that? What do we do when we do that? We're teaching kind of like two things. We're teaching what I would call reflection and refraction, right? So reflection is the ability to sort of say, you know, I'm noticing Kaposi sarcoma, I'm noticing a pattern of injury, a racialized pattern of injury with respect to drowning. How am I understanding that? Well, I guess I could understand that through, there's a few papers that you can look up and understand it. The Kings County in Seattle. You can understand the epidemiology of drowning, right? So that's reflecting. But we need to do more. We need to refract as well. We need to say, what are the determinants of health here that are going on, right? We've noticed this pattern. What are the determinants of health, right? And the determinants of health are going to be, this is going to not be a surprise to this audience, I would say, but the determinants of health are going to be things like, where do public swimming pools get located in cities? Where, who gets to learn to swim? There might be cultural patterns as well, like whose culture values the teaching of swimming. There might be that as well. We have to interrogate that, and where did that belief come from? And if we did that, we would be able to, at the bare minimum, signal the problem, right? So in the case that I told you about there, I did signal the problem to our trauma team, and our trauma team included primary prevention activities as well. And they, it was Canada, right? So there was no data. They had to use the US data to understand it. And, they spent about 3 years trying to build relationships with the multiple Black communities in Montreal, which are separated by language and origins, Africa, the Caribbean, some Indigenous actually as well, and to develop relationships with these communities to then develop community-sensitive primary prevention targeting activities. And I sort of think about that. So I'm going to give you a story of me going to Australia. I went to Australia in 2008. Okay, and I was expecting, first of all, it was almost exactly the other side of the world. So I thought I was going to go to this place that was very, very different, right? And it was very different, right? Like you walked in the park in Melbourne and there were these flying foxes in the trees, right? These massive puppies with wings is what I was calling them, big bats, So very, very different kind of outside surroundings. But I walked off the plane in Melbourne and there was a King Street, there was a Queen Street. Everything had been done in the name of Queen Victoria, just like in Montreal. Like we had a Royal Victoria Hospital, a Victoria Bridge. I immediately knew how the country worked because of my experiences as a Canadian. I go to the medical education conference that was there, and they start talking about distributed education across a vast northern territory. And I was like, boy, that's a really familiar conversation for me, because every medical school talks that way. And then I go and I see the pediatricians are talking about otitis media in Indigenous children. And I'm saying, like, wow, that's exactly, you could replace Indigenous with Inuit and it would be the same conversation. And I guess I was pretty thick, but for me, that was a moment of understanding. I understood colonization as a determinant of health and how it could be so granular as to go to otitis media in Indigenous children in Australia and in Canada. And so that's an example of refraction. So what is that? When you do those things, what are you doing? And what are we trying to do with learners? I think what we're trying to do with learners is develop their critical consciousness, right? So, Brazilian educator Paulo Freire. Some of you may have heard of his work and so on, but he developed a model of two kinds of education. And this is, I promise to get to promiscuity and love at the end, but it has to do with Freire. He talked about two kinds of education. One is the banking model of education, where you put things in people's heads and they actually learn to be unquestioning about the systems and structures that they are part of. So then they actually become part of propping up the systems and structures that they are part of. Does that sound familiar? Because I feel like that describes my medical education, right? And my residency education. Then there was this other model, which is a model where we recognize individuals as conscious and reflective social beings who can see contradictions and injustice, and can commit to act to overcome injustice. And there's a lot of examples of how to get into the instructional methods that work in medical education. I would direct you to the work of Kumagai and Lipson, actually, if any of you want to look that up. Arno Kumagai is a good friend of mine, and he's really I don't know Monica Lipson as well, but their works are very, very worth it. And what is it that we're trying to do when we're developing critical consciousness? We're developing structural competence in people, where the idea is, I used to take my mom every Monday. Well, not me, because it was a different city, but we would take my mom every Monday for an INR. Okay. Because the woman was on Coumadin and she never had a normal INR in her life. It was like a weekly thing for her to go through it. And we would have to give our hospital card, then we would go to the third floor, take our number, wait to be called, all this kind of stuff. Structural competence is asking the question, what would that be like for someone who doesn't speak English? Right? Like, that's the kind of thing that we can sort of talk about at the micro level of our places of work. So I think a really key thing to develop in medical students is the notion of critical consciousness. And if we did that, what we would get is a bit of an ecologic model of disease in the way we talked. Okay. So I had actually a intensive care physician colleague who used to say to me, jokingly, but he meant something when he was saying it, RSV doesn't cause bronchiolitis, right? And what he really meant to say, why this disease to this severity in this patient at this time, right? Why did this patient come to the ICU, right? And if it's an Indigenous patient, as it often is in where I am, why are there 4 Indigenous patients out of 16 beds? Why is that going on? So I think one of the things for us to also think about as specialists and subspecialists is to really hone in on the biopsychosocial, but also I would add sociopolitical, economic, and environmental determinants of health and how they are playing out at the bedside in the patients that we are seeing. And, I'm not going to talk about this too much because I did talk about it, but, we really need to provide places where people can reflect and also refract, right? Like, so they need to see, they need to have, I'm noticing the pattern, but they need to also say, what if we put on different glasses and look at that pattern? Sociologic glasses, anthropologic glasses, and look at that pattern. What does it tell us and illuminate for us about what we're seeing? If we do that, though, we can't be experts in everything. We need to be very interdisciplinary, right? Second case is Neville. So Neville is a 16-year-old boy with myotonic dystrophy. There's a pediatric neurologist in the room, so I have to be good about what I say. So it's a disease that displays anticipation, right? So it's one of those triplet repeat things that gets worse with each generation. So Neville's mother is also affected. And Neville's grandfather, he lives with his mother and his grandfather. They're not, the grandfather is not visibly affected at all. He's one of these kids who started on some nighttime BiPAP, and he comes to the ICU when he has a cold influenza or a respiratory infection. So he's, well known to the ICU. They call him a frequent flyer. Okay. And, there's a psychosocial rounds that's going on where we're discussing, how we get him home and all this kinds of stuff. And people start talking in these rounds, like, oh yeah, they're having a, mother and grandfather are having a break, right? He came to Club Meds. That's I'm betraying all my badness stuff, but it seems to be resonating. I see some nodding. But the medical student watches that and she kind of smiles, but it's a kind of like I should smile, but I'm not sure if I should smile kind of thing. But she smiles, right? And so then Neville gets better. So then 2 months later, the medical student is walking in a little suburb of Montreal called Notre Dame de Grâce. And it's a place, I don't know if any of you know Montreal, but we have frequently these duplexes where you live on top, like one below, one on top. And then even though there's this treacherous winter, they have these wooden stairs that go up. She sees Neville's elderly grandfather lifting him up 50 kilos, lifting him up the stairs. And she says, so good to see you. Why are you doing this? Why don't you have adapted stairs? Well, we went on the waiting list. The waiting list is 17 months. And we're getting close, but it didn't happen yet. She immediately feels guilty at that previous discussion, right? So I think we can call what happened there as an unprofessional discussion, but I'm interested more in what the missed opportunities are, right? And I think the idea here is to really distinguish and to teach about distinguishing a medical history from a patient's story. So I'm going to give you an example. I can be looking after a patient with a head trauma, right? They're having huge ICP problems. They have a, intraparenchymal monitor. It happened because of a car accident, and he's maybe a 16-year-old boy, and I'm, looking after it. Then the next day I round, and I look at the bedside, and mom has brought in a hockey pitcher. The hockey pitcher is the story. All of a sudden, that teenager has a life and desires and things that matter to them that are different, that are worth it, and, he is also someone whose ICP I'm managing, but he has become a real person. And I think what we need to do is provide spaces for both of those things, right? So that a medical history is a different genre than a patient's story, right? A literary genre. Medical history is all about objectivity, right? It's about what is the object? The object is the patient and the patient's disease. And a story is all about their subjectivity and intersubjectivity. And I think different useful knowledge results from each. And this is a fancy term, but medical history taking is a dialectic process. If we think about Hegel and others, this is a process of having a thesis, developing an antithesis, and then synthesizing, right? That's the Hegelian discourse dialectic. But a dialogic process is completely different. It's this story, it's this dialogue where you risk being changed through the interaction. And that is the kind of thing, it happens in medicine. It happens in pediatrics. The thing about it is that it's often a hidden conversation. And it might come out, it comes out because you saw the hockey pitcher, right? It doesn't come out like we need to figure out ways to bring it out in the learning that is happening. And we do that through deep listening. We need to do listening that is attentive, generous, and trusting, and willing to live in the ambiguities that we see. What we need to develop there is a narrative mindset that is humble in its kind of positioning and and this is something, this is a hard outcome actually for me. So we love following patient safety outcomes, but I think we also need to really valorize patient experience outcomes. I think we would learn a lot about our healthcare systems if we valorize strongly healthcare patient experience outcomes. And I think this all of that stuff becomes really, really hard when the medical school says, well, how are we going to assess it? Right? We have to just realize that it's context sensitive, and it may be more about formative development of a person rather than summative evaluations. So case 3. So this one, I apologize to anybody who was at my other talks. I did use this case, but I think it's very important to talk about this in our world that we're in. So I want to talk about a case of an Indigenous youth. So he's 16 years old. He's neurodiverse, and he's also a substance user, right? So he's well known to the emergency department, right? Like he's back or whatever. He comes with his behavioral escalations, and he was brought by the police. He was arrested and brought by the police. And everybody says, well, he just needs to sleep it off, right? They diagnose him as being intoxicated. He just needs to sleep it off. He becomes vitally unstable a few hours later, and actually is diagnosed with internal bleeding because no one really examined him and noticed his flank hematoma. And he actually passes away from his illness. And then what happens is there's this discussion among the learners, and the learners bring it to the residency program committee, and they say, this was it was police violence that did it. This is a case of police violence. Our program has to come out in support of defunding the police, right? So this conversation is happening. And you have kind of faculty members saying, no, that's not our job. Our job is to be neutral. Our job is to be not taking political stances. And they say, is this really our lane? And then they kind of say a lot of the younger learners who are affected by the case, they say something to the effect of, well, I learned all about social determinants in medical school and in pediatric residency. Why isn't it our lane? Right? And this kind of conversation is going on, and then it gets shut down, actually, because it just got too hot. It gets shut down. And some faculty members do recognize some problems with the student's position or the learner's positions. They said, well, I think we should talk about why no one noticed that flank hematoma, what systemic racism, went on inside our care, but nobody even had a chance to talk about it because the conversation has been shut down. So I would like to pose it to you that it's not really about, is it our lane or not, right? But more like, how are we to drive in this lane, right? Are we going to be driving standard stick shift, which they don't have anymore, but I miss? Or are we going to be, silly drivers as we try to do it? I wanted to say crazy, but my kids' school said, they sent a little memo around saying, please don't say crazy anymore. It really got me thinking, actually. And what's going on here? I think what's going on here is an opportunity to think about cultural safety as a paradigm of care. So I don't hear it talked a lot about in the States, but I really think you should talk about it a bit more. Talk a lot more about cultural competence and so on. But it's really, really a big deal in Indigenous health in Canada, Australia, and New Zealand. Okay. And I think it has wide-ranging kind of applicability. So what I want to recognize Maori nursing educator Iria Petty Ramsden, who was one of the women who developed this paradigm. And what she did was she took, in the context of Maori health in New Zealand, she took the medical interaction and she said it's not just going on between a doctor and a patient or a healthcare provider and a patient. It's going on in a socio-political context, which includes injustice and all kinds of things. So that she forced us to see the medical interaction as occurring within a history of structures of marginalization and oppression, asking us to ask why this is happening at this time to this degree and how is this proceeding. And the other thing that she did that was really, really important was that she said that, you know, you don't get to determine what culturally safe care is, the patient does, right? So that was really, really important. That's a picture of the Treaty of Waitangi, which I don't expect you to know too much about, but that's the founding document of New Zealand. It would be like the with that life, liberty, and the pursuit of happiness thing, whatever it is, your thing. And what she did was she related it she related Maori health to that. So we'd be doing a similar kind of idea. And you know, when I think about what does this mean, right? Like, I think health equity is our lane. And here's where the evidence, so this is a line in the Hippocratic Oath that's often used to say health equity has always been there. You know, it says, into whatever homes I go, I will enter them for the benefit of the sick, avoiding any voluntary act of impropriety or corruption, including the seduction of men or women, whether they be bond or free. What, if I translate that into modern vernacular, it says, you know, if I make a house call, I'm not going to sleep with any of the women or men in the house, you know, even if they are enslaved. Okay. So I'm guessing that even in, you know, free love San Francisco, that's not going to be a controversial professional topic. Okay. Like, I think everybody's going to view that as unprofessional. But I think what we're being asked to do today that's a bit different is we're being asked to say, is it our job to also question the institution of slavery, which has made those people vulnerable to sexual violence or not? So are we to go one step further back? And I don't have the right answer for you, but I'm going to tell you that I think shutting down conversation, not a good idea. I think we have to provide our students with opportunities to navigate these conversations. So we need to create an agora where these things can be discussed. And, you know, I wanted to talk about neutrality, you know, so I don't have trouble with neutrality. Okay. I know where it comes from. We're trying to build a space where we treat all comers, right? Like, that's the value behind neutrality. But I do have trouble with thinking of that as not political, right? To be neutral is to be political, right? Is to accept the status quo, all those kinds of things. And I think that, you know, when we have conversations with our students, we should be honest about that as well. And, you know, what we would do there is we would sit there and understand the logics of systems, right? So medicine is based upon white supremacist knowledge systems, right? Like, you know, we can talk about type 2 diabetes, we can talk about all kinds of things. But so much of what medicine is about teaching about and reinforcing a racial hierarchy. I put anti-Semitism and Islamophobia in there, in the racial hierarchy, and we can talk about it after, so kind of like a special interest of mine. But those two ways of discriminating kind of predate notions of race, right? Like, so Middle Ages, even before. And they're stuck together because the tropes are, for one, kind of like, this is Western civilization, but for one are the, you know, kind of internal enemy of Western civilization, and for the other, the kind of like the external enemy of Western civilization. If you look at all the tropes that are used, you'll see that right down to the banker goblins in Harry Potter, actually. So they're really in the racial thing for me. And I'm not the only one. There's people who write about this and all that stuff. I think medicine is also patriarchal, right? Like, so if we teach about, you know, that women present with myocardial infarction symptoms atypically in comparison to men, and we made the social choice to label that constellation of symptoms as atypical, you know, of course, we're going to notice health outcome differences in the treatment and diagnosis and mortality rate of myocardial infarction in women versus men. And then, you know, cis and heteronormativity. So gender, sexuality, and patriarchy often go together. And then, you know, I'm not even going to talk about this very much because I think it's a topic in and of itself, but ableism is a huge part of medical education. So if we dealt with those things in our knowledge systems, we would be doing a really good job. I think we have to deal with those things by remembering that at curriculum committee, where it's discussed, not too many people are at the table who need to be there. So we need to find ways to bring in communities into discussions around knowledge systems. And when I think about it, it's really strange in medicine, right? So to join medicine is to agree to think a certain way, right? Like you agree that I am going to think scientifically. And maybe you didn't agree to this, but it's going to happen for the rest of your life. You agree to be reviewed by peers. All processes are peer review processes, right? Morbidity and mortality rounds. And, through those two things, you agree to be socialized within a professional identity that tells you things like you should dress a certain way. It might tell you you shouldn't have dreadlocks, things like that. But so I have a stable identity that has come from that. Okay. But what I feel is that maybe we need to go for the 90-10 rule or the 80-20 rule. 80% of medical education has to be that, but maybe 20% has to be this kind of education where we critique the knowledge systems of medical through critical race theory, critical feminist studies, queer studies, those different kinds of things, but also really rooted in practice, like in journal club, in places. And that is the notion of pedagogies of love, which I promise to give you a bit of a flavor of that at the end. There's also the respect for other knowledge systems, right? Indigenous knowledge systems. There's an indigenous knowledge system called two-eyed seeing, which is a little bit like the reflection idea that I think we could really, really learn from. It's from the Mi'kmaq people of northern Canada, and it's had widespread resonance in northeastern Canada, like Nova Scotia and so on. And it has had widespread resonance among Indigenous people. So the paper that I know about this is actually an Australian paper where it's talked about. I wanted to give you an idea of two-eyed seeing, or actually refraction. So defining a population. So that's what we do in medicine. We say this is a population, right? And all populations are socially defined, right? But yet we make scientific observations about them. So imagine that we're doing a gene study, gene frequency study, and we're, on the left is our universe, and on the right is a parallel universe with the same individuals in it. So on the left, we have white and carrying the gene is 4 out of 50, and non-white and carrying the gene is 38 out of 50. So what comes from this study is a race-based strategy of testing for the gene. Imagine moving to the parallel universe where what happened was there was this country of people with big feet. And what they did was they conquered the world. And they made alliances with the big feet people in those places that they conquered, and they married them and all that stuff. And they ended up being the upper crust of those countries. So that the world, what mattered in this world was what size your feet were, right? So then the studies carried out there, and we find size 10 feet or greater carrying the gene 2 out of 30, and feet less than size 10 and carrying the gene 40 out of 70. So what we do in this universe is we sort of stratify by shoe size, who should be tested. And I do this to point out to you one kind of fundamental fact about epidemiology, right? Like all populations are defined even when we say at risk of carrying a gene, they're defined socially, and we make observations that are scientific about them. And we need to come clean about that in the way we interpret studies, for instance. Case 4, when the system harms. So this is a baby which was brought in for VV ECMO, for meconium aspiration syndrome. So I was in a hospital where the mother-child part was nearby, and the baby was wheeled over in major distress, and we cannulated, and he had a great outcome, by the way, just to let you know. He's a Black baby. And the reason it happened was the mother had a uterine rupture, And it was like an emergency C-section and hysterectomy. So she comes to visit, like hobbling in the wheelchair the next day, right? Because she wasn't able to come and see him. And she tells the fellow that's on, she says, I kept telling them that the pain this time was different. And they kept telling me to push. So I kept pushing. And, I've had 4 children. I don't know why they didn't believe me, right? And, I don't need to tell this audience in the United States about pain and race, right? Pain treatment, pain recognition, all those kinds of things in race. But I wanted to use this example to show you how that resulted in VV ECMO, or contributed to the creation of a baby that needed VV ECMO, that went into fetal distress to that degree that they aspirated meconium and needed VV ECMO. And, I think something we need to do, a little bit like the case with the Indigenous person, we need to look inwardly. We need to look at systemic structures of discrimination in healthcare. I'm not going to talk too much about the one on the left, but the one on the right is a paper that should be rocking our world. This paper in Pediatrics looked at perioperative outcomes for very mundane surgeries, like TNAs, all those kinds of things, in the United States, and found mortality differences. So important, based upon race. Important to note there is that the kids were seen and judged as being ASA category 1, or, like low risk. So somebody saw them and judged them to be low risk, but yet they still had mortality outcome differences. And it really got me thinking about perioperative care as a system, from, the consult to the anesthesia preoperative clinic, to going into the OR, to recovery, to going home, right? And I think we need to think about, like in ICU, we need to think about, fetal diagnosis to surgery to follow-up for cardiac care. And what I think we need to do for that is we need to add a new bone to our fishbone Ishikawa diagram. So we can't, I don't know, you might use different, but I normally talk about procedures and policies, equipment, and human factors when I'm thinking about patient safety. I would pose it that we should add a 4th one, systemic discrimination and racism, and that should be regularly talked about at a patient safety meeting, or at a, and you could dismiss it. You could sort of say, no, there wasn't, but it always comes up in the root cause analysis that you're undertaking. And I think that that's an opportunity to teach trainees to not trust the system as necessarily benign. And if we did that, we would come up with clinical skills that I would say are about liberation and solidarity with the populations we serve. We would act with our populations, with our patients, rather than for or on. We are empowering them. We're listening to their stories, because their stories teach us a lot about the experience of care. And, we would share solidarity with them, but we have to recognize that there are different struggles. Like, I think the Indigenous struggle in Canada is like off the charts. Okay, it needs to be managed as an emergency. Okay, that I just give one from my own country. And then we would come up with a new clinical skills paradigm where, the arrows maybe go both ways in all of the things, where we take a history, but we hear a story, where we think of a disease affecting health, but a patient maybe can alter a disease as well. And that we are willing to apply different paradigms to the things we are seeing. And of course, because I'm in ICU, but all of us really act in uncertainty, ambiguity, with difficult moral choices, but also like we got to do something. We got to act. I want you, I'm getting to the end here, but I want you to remember, so on the left, does anybody know what unifies all those pictures? Just call it out. Africa, yeah, could be. Malaria. It's, and the mosquito net is a very nostalgic thing for me, because I remember that in Trinidad, where we, did that every night, and then we wrapped it up every morning. And those are pictures of malaria. So I want a doctor that loves to look at smears. Okay. I actually got smears like this for my kids' bedrooms. It got vetoed with the move. I don't know why, but I really love blood smears. But there's the wonder of looking at smears, right? Like science. But there's also, making mosquito net policies as well, contributing to that. And, I put Lieutenant Uhura up there because she's, she spoke Klingon, and she was a lady in the future, a Black lady in the future, someone that showed me that there is a future for all of us that looked good. So I have a couple metaphors, like, what do we need to do in medical education? We need to stop having only a hammer and treating everything as a nail. Right. So the metaphor that I use is a bit risque, but maybe that's the promiscuity idea. I won't say the real one, the real metaphor that I use. But I think the thing that I want you to know is that there needs to be a space for things like sociology, anthropology, not too much of a space, but a space in the way we learn and look at the world so that we can actually treat patients better. And what is that? So the fancy word is phronesis. Some of you may have heard about this. This is the idea that so I'm going to say that when someone graduates in critical care, I can say you have attained all the competencies of pediatric critical care medicine. Or I can say, God forbid, you could look after my children. And those are two different things, okay? And the other thing is someone who has phronesis, someone who has prudent action in the world. And I think that is, and if anybody wants to look up kind of the instructional methods of that, like how do we teach that, I would look up the work of Boudreau and others. We can talk about it I don't have time to go into all of that, but that's more like a workshop-y kind of thing. So I think what we're doing there is what Freire called pedagogies of love. And I say thank you, Miss Christie, because Miss Christie was my grade 1 teacher. So she represented kind of waspy old stock Ontario, but she had a class completely full of people from all over the world, right? Like she had like people like me from all over the world. And she did stuff that I think Freire would have liked. She asked us to pose problems, to be curious, to be exploratory, to examine our own positioning. And we would then develop critical consciousness through an examination of context and relationality. And I think in medical education, in residency education, we need to do those things. So that's love-based medical education, where there's critical consciousness, solidarity, where there's a balance between normalizing pedagogies and critical pedagogies, all done with humility, in a idea of narrative. And I would just say that, I think of ICU. I used to say that if you asked me to describe what ICU is in 1996, I would have said, I support organs. In 2008, I might have said, I know what I'm supporting them for, the brain. So a little bit of the neurocritical care idea. For me, what works in 2024 is I see the collision between a patient's social context and high technology medicine. That's the one that works for me now. And what I'm sort of thinking and teaching about. Lastly, I just want to say, that as a subspecialist, all I am is the parsley on top of this thing, right? So that parsley is Italian parsley, means that we're in a very good restaurant. So the healthcare system can afford me. But that roast beef is really the vaccination of children, the learning to read and write, all these kinds of things. So that, I think as subspecialists, we can develop a kind of humility to be part of this larger whole and a continuum of care. So I'll stop there and say thank you very much.